Hello, everyone. Welcome to the webinar. It's 7 p.m. and all the panelists are logged in. We're giving a little bit of time for the attendee roll call to increase, and we'll get started here pretty soon. Okay, it's 7:01. I think we should get started. Welcome to the North American Neuromodulation Society Education Committee webinar. We're going to discuss pediatric neuromodulation today. Thank you all for being here with us. This webinar is 1 hour in duration, and it will explore cases in pediatric neuromodulation in the 3 pillars of functional neurosurgery, which includes pain, movement disorders, and epilepsy. The format is open and interactive and consists of interesting cases which have been prepared by our expert panelists, followed by faculty discussion and questions from the audience. It is intended to be a case-based interactive discussion with experts. An in-depth review of any one topic is out of the scope, but could be very interesting for a topic in a future webinar. Irina, would you like to discuss?
Hello, everyone. I would like to introduce my moderator, the moderator of this webinar, Dr. Jeffrey Raskin. He's attending neurosurgeon and assistant professor in Department of Neurosurgery and Robert Lurie Children's Hospital of Chicago at Northwestern University Feinberg School of Medicine. And I would like to introduce myself. I'm a postdoctoral fellow in Department of Anesthesiology and Critical Care Medicine at Johns Hopkins University School of Medicine.
Thank you, Irina. So it is my distinct privilege to introduce our expert panel of discussants. Each of our panelists really need no introduction, as they are all internationally known with appropriately long and impressive CVs. But in the interest of time, I will highlight their academic roles and affiliations here. We have Dr. David Adelson, who is the Diane and Bruce Halley Endowed Chair of Children's Neuroscience and Chief of Neurosurgery at Phoenix Children's Hospital. Dr. Giovanni Cucciaro, who's Professor of Anesthesiology at Johns Hopkins University and All Children's Hospital in St. Petersburg, Florida, Director of Perioperative Services. Dr. Dan Curry, who's Director of Functional Neurosurgery and Epilepsy Surgery and Endowed Chair of Minimally Invasive Epilepsy Surgery at Texas Children's Hospital and Professor of Neurosurgery at Baylor College of Medicine. Dr. John Honeycutt is the Medical Director of Pediatric Neurosurgery at Cook Children's in Dallas, Texas, where he's been since 2005. And Dr. George Ibrahim is a pediatric neurosurgeon at the Hospital for Sick Children and assistant professor at the Institute of Biomaterials and Biomedical Engineering, the Institute of Medical Sciences in the Department of Surgery at the University of Toronto. Truly, thank you all for being here with us tonight. Irina will now talk about the ground rules and get started with our first cases.
Thank you, Dr. Raskin, for introducing our panelists. Before we start, I would like to tell you a few rules of our webinar today. All of us are going to be muted during the meeting. Please write your question in the question panel on the left side of the screen, and we will answer them while they appear and in the end of the presentation. The recording of this webinar will be available in 48 hours after this meeting. I would like to start our webinar with the pain section and cases kindly provided by Dr. Giovanni Cucciaro. Dr. Cucciaro.
Right. Thank you, everybody, for the invitation and asking me to share my experience with the use of devices like a spinal cord stimulator and pump for the administration of medication into the subarachnoid space. This is a kind of a controversial topic in the sense that if you look at the literature, there is not much said about the use of these devices in children. And actually, if you find a couple of papers, you will see that there are people who object to the use of these devices, while instead there is a lot of information in the adult literature. So let me start with giving you two examples of use of these devices, of the spinal cord stimulator, for example. And the question is, many people may have, why to use a spinal cord stimulator or on a pump for the infusion of medications. And the way I based it, again, I didn't have much information on the literature. The day I decided to try these devices, is just went for the basic symptoms that the patients had, and based on whether the pain was a neuropathic in origin or somatic. And so in case of neuropathic pain, I decided to try spinal cord stimulators. And this is a girl, the first case is a 15-year-old girl with erythromelalgia. As you know, erythromelalgia is a condition related to a deficit of a sodium channel on the nerve fibers, and that results in severe pain, which is burning, mostly a burning sensation along with paresthesia and allodynia, of course. And this girl, and actually typical of kids with erythromelalgia, was having major problem ambulating, and so was wheelchair bound, and also was using ice water. Is a common trait of these patients, because the burning sensation is such that they get some relief by immerging their extremities into ice water, which is over time causes significant problems with the skin, with infections, desquamation, and so forth, and so abscesses, and so forth, and so on. And this girl has been coming to the hospital for 2 years before I finally decided to put the spinal cord stimulator, because the pain was not managed by any medication we had, including opioids and gabapentin, Lyrica, and on and on. And because again, the girl was miserable, we decided to try. We did first a trial with the spinal cord stimulator, and she felt way better. And so the next step was to implant the device. Were we able to get a full relief from pain? I would say that the pain, from a pain score of 10 went to 4. And at that point, we decided to add the medication. We added mexiletine, and that was able to bring the pain all the way to an average of 2. And so the girl was actually finally able to wear shoes, was able to walk, and go back in school, a regular schedule. And so basically going back to a normal life. The second case is a case as a 16-year-old girl with Klippel-Trenaunay syndrome. And as you know, or might not know, but is a malformation, a vascular lymphatic malformation. And she had basically a huge left lower extremity. And she was unable to walk, so she was a wheelchair bound, and she had been hospitalized several times over the years just because of this persistent pain she was having in her leg, which she described as, again, a burning sensation, and mostly burning sensation. We did a trial first with placing an epidural, and without much success. So we say, okay, let's do a trial with the spinal cord stimulator. Because what happened is that you can see in the slide on the right-hand side that the patient had an amputation because, again, the severe pain and the deformity of the extremity was stopping her from being able to walk. And so she went for an amputation, above knee amputation, and what happened afterwards is that she developed a neuroma on the level of the sciatic nerve, and that was stopping her from wearing a prosthesis. She couldn't wear a prosthesis because of the pain caused by the neuroma. And actually, the surgeon, the plastic surgeon, went back in trying to resect the neuroma, but the deformation of the tissues and the blood components and so forth and so on, preventing him for even finding the end of the sciatic nerve. And so we first, again, as I said, we tried to put an epidural catheter, didn't provide much relief. And so the next step was to try a spinal cord stimulator. And we placed a spinal cord stimulator, and that was effective. She was able to get off hydromorphone, get off methadone, and gabapentin. And actually, the last I heard from her, she was actually dancing. There was a clip that she sent that she was dancing on the floor. The next slide. Instead, we should focus on the couple of cases where I use, and I'm sorry for the title, but that doesn't apply. It's not the spinal cord, our example of not spinal cord stimulator, but of an implant of pumps. And the first kid here is a 19-year-old boy who was vaccinated from polio, and unfortunately he developed polio after the vaccination. And so eventually, as you can see, there is a significant deformity of the spinal cord. It was tried the surgeon to do posterior spinal fusion, but he failed because they lost signals during surgery. And so he was wheelchair bound, and unfortunately he couldn't sit on the chair for much longer because of pain. And so he wasn't able to go to school, he wasn't able to have a social life, he liked to go to play bingo, and on and on. And so again, the patient, we treated him with opioids, we treated him with gabapentin, with Lyrica, and without much success. And so we decided to go to implant the pump. So now is usually when we start with hydromorphone and bupivacaine, like I guess most of what happens in the adult world, and then and the patient gets immediately relief in a way, and was able again to sit on the chair for basically the entire day as long as he wanted. The second case you see on the right-hand side is a kid of 19 years old with severe mental retardation and cerebral palsy. And as you can see, him too had this significant scoliosis. And for surgery, he had a posterior spinal fusion. However, all of this was complicated by the fact that he have a major bilateral hip dislocation. And that was causing that was the major source of pain for him, to the point where it was bedridden. He couldn't be on even they built a specific wheelchair for him in order to accommodate his curvature and his body, and still he couldn't sit in a wheelchair. And also every time he was moved from the bed because of cleaning, to wash him, to feed him, and so forth and so on, it was an excruciating pain. And so it again is a kid where we tried every medication, and you know, we don't have many medication when it comes to pain management. And so even opioid is the last resort. It was on methadone, it was on diazepam, baclofen, oxycodone, gabapentin, and none of that was helping. And so we resorted putting on a pump, which actually I did it with the help of a neurosurgeon because of his hardware that you can see on his spine. And think that made a huge difference with respect to his quality of life, not only for him, but also for the mother, who was able to move him, mobilize him, and helping him with his daily activity. So these are basically the cases that, an example of the cases that I had. And if I can tell you, and then I don't know if you have questions about this later on, but the major challenge that I face, it was with kids with spinal cord stimulator, because it is very difficult for adolescents to be compliant with the use of the spinal cord stimulator. I had kids who had forgotten to or didn't care about it, so they didn't charge the device, to the battery, to the point where I had to replace the battery. I had kids who actually fall off the follow-up. and because they say, oh, I can't deal with this device, I don't want to use it, and we place it specific on this kid when he was 16 years old. And he came back later on when he was 18 years old saying, you know, I am in too much pain, I want you to recharge my battery and teach me again how to use the spinal cord stimulator. So the compliance of kids with the spinal cord stimulator is that's the major challenge. With respect to the implant of pumps, the major problem is the selection of patients, just to make sure that the patient is the right patient and that will keep the pump, because we had the case where I implanted the pump on a girl who was with sickle cell disease and who had the severe AVN of both hips. And after a positive trial with an epidural, we proceeded to put the pumps. Fortunately, the girl has been, as many of these sickle cell patients, treated with high doses of opioids to the point where she developed physical and psychological dependence on the opioids. And so after 6 months that she had the device, although she was not admitted to the hospital because of pain, and while she had been admitted basically on a monthly basis before the implant because of pain, she asked to remove the pump because she would rather have opioids. And another case was where he places a pump on a kid autistic kid with autism, and who had a slow growing intra-abdominal growing cancer. And again, this is a kid who was in a hospital, you know, every other month because of abdominal pain. And at one point, we decided to put the pump. And unfortunately, it was a fairly severe level of autism. And so at one point, he refused. He felt like he was a teenager, 17 years old kid, and he couldn't tolerate the pump. Just touching the abdomen, looking at the abdomen was making him very upset. And so the mother, although she recognized the value of the pump, she said, you know, well, I can't live like this, because he wants the pump out. And so it's a kid where we ended up removing the pump.
Dr. Kuchero, sorry to interrupt you. I mean, these are great questions, and these are great cases, very complex. I do want to make sure we get to some of the questions that people have for you. Thank you for sharing these. The first, with respect to the spinal cord stimulation, the first question from an audience member is there a difference in how you choose where to stimulate in the pediatric population versus the adult population?
No, it's exactly the same. There is no difference. The question is, I implanted this spinal cord stimulator, a relatively young kid, even the one who was 15 years old. Then the question comes once there is a growth, and so is the device is going to still work as the kid grows. And so unfortunately, I left Los Angeles, and I left these kids, and so I don't really know what happened now, you know, 4 or 5 years after I implanted this pump.
Yeah, we need a national registry.
I'm sorry?
We need a national registry where we can track these patients around the nation.
I guess, but the indication for placement is exactly the same as in adults.
Great. There's not very much evidence in children for spinal cord stimulation, but there's even less evidence, I think, for pain pumps in children. You brought up sickle cell crisis, which is a very interesting condition. How do you get those patients in your clinic? How do you sort of facilitate that pathway?
Well, these patients, as you know, they are frequent flyers. They are in the hospital very often because of sickle cell crisis. And sometimes it is always big confusion between a pain from sickle cell crisis and pain from, for example, AVN. of the femoral head, as an example. And so, these patients, we as a pain service, we follow the kids in-house and as outpatients. And so that's where I had these patients, because we met them in the hospital, and then we kept doing the follow-up once they they go home. So those are where I found, and where even now I put a pump recently on a young girl, 15 years old girl who had been hospitalized for a chronic abdominal pain multiple times, resistant to any sort of medications. And she was probed and poked and tested everything, and nobody could find the reason for the abdominal pain. Patient non-functional at home, not in school, not playing sports because of abdominal pain. And although I recognize that there is no diagnosis, one day I say, okay, we can go on like this. Let's try to put an epidural. The epidural took care of the pain. We put a pump. Now she's pain-free. So my mind, these are indications where we have no other options left. When we tried everything, we tried the 3 medications that we have available to manage pain, and because of the side effects, because of the potential addiction issues and so forth and so on, I think that these devices are a very good option.
I don't disagree. One thing is that they can be trialed. Someone has a question about whether or not you do trial with morphine injections before implantation, or maybe even do serial injections of morphine, and then that might lead to not necessarily needing to implant a pump.
No, I just do, actually, to tell you the truth, I just do a single injection, a spinal. I do a spinal morphine and lidocaine injection. And if I have a response, for the following hours and 24 hours, I say that's good enough for me. So occasionally you put, as I said before, occasionally you put an epidural, but as you can see in these kids with severe scoliosis, for example, or hardware, it's very hard to do. You can't do an epidural. And so we go straight for a spinal injection of I usually use lidocaine and morphine. Or hydromorphine.
Yeah, we appreciate the discussion. As we talked about in the beginning, we could probably go a whole hour on any one of these cases, but we do have to move on due to time to the next section, unless any of the panelists have anything else to chime in about neuromodulation and pain.
Okay. I have a question for Dr. Cucciara, and we will move to the next section. So, Dr. Cucciara, as I understand, so there is a spinal, difference between spinal cord stimulation and pumps. Is the etiology related? So, what are really indications? So, based on these cases you presented, it's actually the level we're going for stimulation. If the level of pain is very high, there is a failure of conventional treatment, but still, when we're choosing spinal cord stimulation compared to baclofen, I'm sorry,
morphine. Again, I followed it wrongly, rightly or wrongly, exactly because there is not much in the literature to support either way. I follow, there is a neuropathic pain, or is it visceral pain or somatic pain. And so if it's a neuropathic pain, my sense is that, like in adult world, you place in a spinal cord stimulator. If the pain that doesn't have a neuropathic component, I will use a pump.
Yeah. Makes sense.
Great, thank you so much. We'll move on to movement disorders. The first case is from Dr. Honeycutt. Dr. Honeycutt, would you mind taking us through your case, please? I think you may be muted.
Dr. Honeycutt is muted.
Yeah. It was definitely working before we went live. We checked.
Lily, could you?
Maybe we should just move to Dr. Ibrahim's while Dr. Honeycutt figures out. Okay, he's shaking his head, yes. Irina, would you mind progressing through the slides to Dr. Ibrahim's case?
So I hope you can hear me. I don't know. Am I audible?
We hear you.
I can hear you.
You're audible.
Okay.
Okay, Dr. Ibrahim, you have the floor.
Wonderful. So thanks so much for having me on this panel. I have a brief case to discuss related to management of dystonia with deep brain stimulation. And this is a boy who I treated, I think last year or a year and a half ago, who's 12 years old, who has cerebral palsy. And those on the attending might know that acquired causes of dystonia are actually quite difficult to treat. And neuromodulation for acquired causes of dystonia tend to be less satisfying than inherited causes of dystonia, genetic causes specifically. But this is a boy who was born preterm, had clear cerebral palsy as the etiology of his dystonia, and he presented to us quite unwell, quite sick. He had a mixed form of cerebral palsy, both spastic and dyskinetic, and he was on several medications. But over a period of a few months, he had very rapid worsening of his dystonic movements. He was treated with baclofen. He was in and out of hospital. Several oral medications were attempted, and ultimately he was admitted to the intensive care unit in status dystonicus, so quite unwell. And at the time that he presented to us, he was treated with 8 anti-dystonia medications. So really quite severe. And in fact, he'd been in the intensive care unit for several weeks in a different province in Canada when we were alerted to his condition, and he was transferred to our attention for urgent insertion of GPI DBS due to his medical emergency of status dystonicus. Next slide, please. I do think that a picture tells 1,000 words, and a video is critical for assessment of movement disorders. I'll ask you to play the video on the left, please. And this is this child's appearance when we first saw him. Please go ahead and play the video on the left if you're able to. You'll just have to click on the video, and there's a little play button at the bottom that you'll need to click to start it. The video is embedded. There you go. So essentially, he was in this state for several weeks when he presented to us. Again, trialing several medications, one at a time, without any benefit, again, requiring an admission to the intensive care unit. And the video on the right is 6 months after the deep brain stimulation. You could see he's at home. He's not in a hospital setting. And clearly his dystonia has improved to a significant extent where he's able to function much better. We do collect prospective data on all of our DBS insertions in children. In fact, we do have a database that we manage. And if you are able to go back to that slide, you see that the
I'm trying to start the video. Sorry, I ran through. Let me come back.
No problem. Take your time.
I was trying so hard to start that video because
You got a little live webinars.
So it's not the correct slide.
progress. 1 second.
Sure, no problem.
Nobody look at these.
Yeah, I don't know.
Wonderful. So if you can move forward one slide.
Okay. It will delete it. It is great. Yeah, we're not gonna to try again. Let's. Yeah, on the left is working, but not on the right.
Wonderful. So
Okay,
so this
yeah.
Thank you so much.
I'm sorry. Okay.
So this is the database that we collect prospectively, where we collect not only outcomes based on the dystonia, but also quality of life outcomes in these children, which I think is really quite critical in moving the field of neuromodulation for children forward. Next slide, please. And you could see on the left that the BFM-DRS score, this is the dystonia rating score that we see, improved quite significantly pre-DBS to 6 months post-DBS. Usually about a 20% change is a clinically meaningful change in the BFM-DRS. But more importantly is the change in the quality of life, which increased quite considerably in a very short period of time. And this is the delayed data that I'm showing from 6 months to 12 months. And that highlights the point that improvements after DBS continue over a longer period of time, over several months after implantation for movement disorders and dystonia. And I think one area that's going to be increasingly important moving the field forward is to rely on outcome measures that measure quality of life, that measure parental and caregiver quality of life after DBS in children, rather than simply the motor disability scores such as the BFM-DRS or the Berry Albright scales. But this is one case that demonstrates an emergency use of DBS in a child who presented in status dystonicus, in extremis in the intensive care unit with outcomes that are really quite satisfactory. And I'm happy to say he has not needed to go back into the hospital since his DBS insertion.
Thank you so much, Dr. Ibrahim, for your case. Dr. Raskin, do we have questions?
Yes, that's really truly incredible, Dr. Ibrahim. I noticed that the 6-month post-DBS is the endpoint for the BFM-DRS. Is that just due to limitations of follow-up, or is it sort of, level out there at the improvement of 40%?
No, this is just what I put together for this talk, Dr. Raskin. But in fact, we do have within our database outcome measures that go up to 3 years. So this child was treated about 18 months ago. We do have longer outcome measures, and I could tell you that the reduction in dystonia and the improvement in quality of life has so far been sustained for this child. And again, he's not required hospitalizations, but we have measured outcomes for him well beyond the 6 months interval, and we continue to do so. He's still a part of our prospective data collection.
Great, thank you. There's a question from an epilepsy fellow at Sick Kids, Dr. Ranjit. Was a coexisting genetic condition ruled out in this patient?
Yeah, great question. So this child actually did have a very, very thorough genetic assessment, because you're absolutely right. Preterm birth, even imaging evidence of cerebral palsy does not exclude a coexisting genetic condition. And this child's response has actually been quite favorable, above and beyond what's typically reported for acquired dystonia. So we did actually ponder that, but so far the genetic testing, including whole exome sequencing, was not indicative of any secondary genetic diagnosis.
Yeah, it's becoming, I think, more of a question of, are patients born early because of an underlying genetic condition, right? And then they're labeled CP, but do they actually have a coincident neurogenetic condition? I think Dr. Honeycutt published a series comparing like DYT1 and CP patients who were implanted with palatal stimulation, and found that if you had improvements at 6 months, then those tended to stay, whereas DYT1 patients tended to improve more over the long term. So interesting to sort of look at these patient populations again and try to understand why are the secondary dystonic patients improving, because it may inform future patients. There are no current other questions. Thank you for your presentation. I think we should move to Dr. Honeycutt's discussion, which will also be on deep brain stimulation for dystonia. Can we hear you yet, Dr. Honeycutt?
Yeah, can I ask one question to Dr. Ibrahim? Why GPI? Why this target? Is it?
Yeah, no, that's actually a really good question. So we actually did a meta-analysis a few years ago of about 300 or 400, between 300 to 400 cases of pediatric dystonia treated with DBS, and GPI is typically the traditional target. The vast majority of targets chosen are GPI. There are actually very compelling arguments for other targets for dystonia as well, including thalamic targets and others that are more investigational. But the largest body of evidence really is for GPI, and that is, in general, our preferred upfront target. Now, certain groups, others certainly on this call will tell you that you could potentially test different targets. Some people are doing multiple implantation in different regions in the brain that are relevant for movement disorders. But our practice is to start with the target that has the largest body of evidence before moving forward to others. And so far, we actually have not needed to consider other targets in the management of these patients because of unsatisfactory results. But I'm sure as we build our experience and our database, that will be the case.
So is it etiology, because dystonia can be different, it's primary or secondary like here, is it etiology related or is just because effect?
No, it's targeting the movement circuitry using the GPI as a node. And in fact, for acquired or primary or secondary dystonia is a bit of an older term for etiology, but for acquired or inherited causes, the primary target remains the GPI for both.
Okay, thank you.
So there is evidence for other targets too, and I think the future will see more personalized target selection for patients, but I don't think we're quite there yet.
Yeah, this is what I was trying to ask you in here. Yeah, this is the future. Let me go back to Dr. Honeycutt's slides.
Can you hear me now?
Yes.
Oh yeah.
Loud and clear.
Santa Claus has trouble with technology sometimes.
Yeah, no problem.
So case presentation is, appreciate the chance to chat with everyone tonight, but 14-year-old male, he had dystonia with significant tremor, a myoclonus epilepsy, and he also static encephalopathy. And over time, he failed medical management and progression of his symptoms. A DBS was placed in his bilateral GPI with a rechargeable generator with our IMRI sleep protocol. It initially did well with this, but over time, either it's disease progression or maybe just fading of the benefits from the DBS, he ended up having more problems. And so we thought, is there other targets that we may be able to employ that would be more beneficial to him? So we've now started a process on more difficult patients of actually placing DBS SEEG leads and then do stimulation for other nuclei. So after a lengthy discussion with the family and our team, we took him to the OR and with a robotic arm, placed multiple SEEGs into his bilateral VIM and bilateral STN. And we've learned over time that the target for STN actually will go right through the area of VOA. So we've now started using 16 channel electrodes in this target, and you can stimulate both of those with one electrode. And so we haven't done a whole lot of recording, although we've started to do that. But for him, we mostly just was stimulating a couple of days in the hospital and found that the STN seemed to be beneficial. So next slide, SEGs were removed, and then roughly about a month later, actually for him, it was quite a bit later, we came back in and placed second leads into his STN with a second generator with the same sleep protocol. And so I included on this slide just his, on the left-hand side, his pre-op T2 MRI scan. or inversion MRI scan. So his anatomy is pretty good. Some of these kiddos can have really difficult anatomy with large ventricles and atrophy, and sometimes the nuclei are very atrophic, so it can make it difficult. And then the middle one just shows his leads already in place, but new ceramic stylettes down to the STN that we're trying to do. And then the last one, just a CT scan showing the bilateral electrodes in place. So we have about 10 patients or so, a little less than that. We place these DBS SEEGs in both after they've already had electrodes in place and also sort of more difficult dystonic cases, most of them being secondary with more tremors and other things, looking at other targets. And surprisingly, some of these kiddos, VOA seems to be a really interesting nuclei that seems to respond well in these cases. So we're starting to shift our thinking that of doing more of these temporary stimulations to see if we can actually tailor the DBS to each individual patient. It's not the standard for us, but it's in our arsenal now.
Yeah, that's incredibly interesting. I mean, I think this somewhat is a good case, actually a good case to follow Dr. Ibrahim's case, because it's a little bit, more nuanced with the addition of stereo EEG electrodes. I guess while people are coming up with questions, the EEG electrodes that you're using, those don't at all mimic DBS leads, right? So how do you understand the signal you're getting, and how do you convert that to a stimulation pattern that might approach a deep brain stimulation electrode?
We are just starting to play around with actually recordings and see if that will guide us as to what the stimulation pattern should be. But it's been a process of trying to find old external stimulators for awake microelectrode recordings so that you can hook those up, and having just the equipment. And so we've been scrounging around the country to make sure we have enough stimulators over time because they're difficult to find. So it's a whole process of getting that sort of set up. And it really is just, you just try it, and then after about 30 minutes, you move on to the next one. And so it's very labor intensive for our neurologist over several days to do this, and exhausting for the patients.
Yeah, got it. Someone has a question which I think is on everyone's mind. Is this patient part of a clinical trial? And if not, how do you ever get insurance approval for this?
Yeah, we've been very lucky. So this is, for DBS for dystonia is an HDE, and so we have gone through our IRB for every single one of our patients as part of, protocols and to get consents and so forth. So for us, it's actually been fairly easy for most of our patients. Some of our out-of-state patients, Medicaid can be a challenge for those, but we've been doing it long enough that we've actually not been too bad on that. But it is changing a little bit over time, a little more difficult now than it was a decade ago.
Yeah, I think one of the challenges with pediatric neuromodulation is that we're always adapting adult hardware basically to pediatric patients. Many of these are adolescents, but still they're cachectic and they have pediatric diseases. I wonder if you and Dr. Ibrahim might comment on any strategies, surgical strategies you might use to decrease the complication rate.
Our protocols has to be above 7, so that makes it a little bit easier. It's about a pretty normal, sort of normal head size. But some of these kids are pretty thin, so you have to, I've not had issues or too many issues of healing, but you do have to be careful and just, as in with like a shunt on a kiddo, plan incisions carefully and so forth.
Yeah, and the youngest child that I've implanted was 3, kind of also a very desperate situation where DBS was really the only option available. And we debated implanting the IPG in the abdomen instead of the chest, but actually even in a 3-year-old, we followed the same procedure, and it actually went very, very smoothly.
Does anyone use countersinking of the sort of hardware as a method to try to decrease the profile? No.
Well, I don't think that's necessary. I do think that if you're implanting in children who are younger than 5 or so, then there's a very good chance that the electrodes will eventually migrate, and the intracranial electrodes will need to be revised at some point in the future. But I've not followed the younger children that have implanted long enough to need to do that yet.
Got it. I really appreciate that case. They're very interesting. Unfortunately, we do have to move on. So we didn't get to talk about a lot of neuromodulation in movement disorders, of course, like intraventricular, intrathecal baclofen, for example, and many of these same cases would be managed at different institutions in a different way. So we appreciate it. Hopefully in the future, we'll be able to bring you back for a more in-depth discussion, but we'll move on to the epilepsy portion of the evening and start with Dr. Adelson's case.
Yes, hi, good afternoon, good evening. So this was an interesting case of a 15-year-old young woman who had suffered from autoimmune encephalitis and status epilepticus. This was eventually resolved, but you can see sort of the list of medications and treatments that were utilized in her particular case to try to gain some control of her seizures, really, which was not very successful. You can see her workup. Imaging was, for the most part, normal. She had a little bit of atrophy, but no real focal areas of hypometabolism. Video EEG showed a number of different bilateral independent seizure onsets, and we did a resting state on her, which also showed possible multiple seizure onset zones. For that reason, she went on for SEEG, and really with the idea to see if we could identify a dominant type of seizure focus and sort of go from there. We did place SEEG, and I'll just show a picture of the configuration. Actually, if you want to go ahead and do that on the next slide, you can see just sort of the diffuse nature at which we targeted. But interestingly enough, her seizures were really a fairly rapid onset. What we tried to do was to look at where there was sort of predominance of her seizures and where they were most often. So what we found, unfortunately, was multiple seizure onsets on the left hemisphere, but then what seemed like also a fairly focal onset within the right amygdala. So in this case, the reason to present it was to sort of talk about an interesting approach now utilizing responsive neurostimulation. If you can go to the next slide. We ended up implanting her bilaterally with RNS, but using a deep target into the centromedian nucleus on the left, but a surface electrode on the right amygdala. And then you can see the configuration there. And this was based really off the high frequency oscillations that we identified during her SEEG targeting. She's had some improvement in her seizures, but again, as I mentioned, she had bilateral and fairly extensive foci. At this point, we only had the 2 electrode system. I think, again, we had 2 other seizure onset zones that we could potentially target that were sort of next on the list of contributing to her seizures. But this was just an example of being able to utilize both sort of a deep brain strategy as well as a surface or even a more cortical depth strategy utilizing this technology. Thank you.
That's fascinating case. Yeah, thank you for presenting it.
David, I've got a question.
Please.
How did you target CM? I've got one that I've done, and I struggled about how to figure out how to do that on a kiddo.
Well, this child's 15, so I mean, she had a fairly adult type brain. We used we just used a Lexel frame and targeted using pretty much standard targeting for that. We used the MRI. We like a couple of the inversion scans to try to tease out the nuclei, but it really was based off ACPC off midline, and then, you know, sort of targeting from, you know, basically the coronal suture to give you that trajectory.
Yeah, John, that's what we've been doing, and it's indirect mostly. And you're right, we don't really see the nucleus, David. I'm never really convinced I'm looking at it. I mean, it's very
yeah.
indirect.
And then, I mean, and that could be the possibility of, like, maybe you could get better, what's it called, you know, seizure outcome, maybe if I were, but we believe we had good targeting. I think we measured that we were 1.3 millimeters off of the plan. I felt like the plan was right to centromedian. So I think we were pretty close.
There's one question about why was CM chosen and not anterior nucleus of the thalamus?
Very good question. One of the things that's come out with the RNS sort of DBS hybrid is kind of localization of where your seizures are coming from. These were frontal and central, the ones and diffusely, and so we chose centromedian. If it was more frontal, we would have gone with the anterior nucleus. If it were more parieto-occipital, we would have gone for the pulvinar, and that's kind of at least the present day thinking for the use of this type of targeting with the RNS. There's a very small literature so far on this, only maybe about 40 patients with deep targeting using the RNS system.
Yeah. Do you do it in a standard stereo EEG yet? Are you standardly putting CMs in or anterior nuclear groups in?
We have not done that yet, no. But that is something that we've discussed, but we haven't really identified a patient where that's really an appropriate, we've not found the appropriate patient yet.
Dr. Allison, thank you so much. It's 7:52. In the interest of time, we'll move on to Dr. Curry, the last case. Dr. Curry, you want to take us through your case, please?
Yep. Thanks, everybody, for the invitation to talk. Sorry, I'm talking from a Starbucks due to an over-eager IS department at Texas Children's, and I'm going to go through this RNS case pretty quick. It's a multimodal therapy of periventricular nodular heterotopia. First slide, please. So he's 16. His onset was at 13. And when he presented to us, if you can go to the next slide, there you go. You can see his MRI has pretty considerable periventricular nodular heterotopia in the atrium and the occipital, and really not worse than one side or the other. Can we back it up a bit? Those are like actually the hidden slides.
Presentation moves by itself without me.
Yeah, I know, it's a little touchy. Anyway, we thought this kid, he had a funny smell when he began. He had a behavioral arrest. He walked in circles, but he didn't have aversive head movement, and he didn't walk in circles in the same direction each time. So he was a little unclear enough for us to, on his non-invasive study, even though his MEG was temporal, his EEG was temporal, his behavior seemed temporal. We still thought that we should study him invasively, and so we did so. And there is a map coming soon. If you back up one slow tab at a time, and I'll show you his first stereo EEG study, which mainly concentrated on the right side. And I put electrodes in the you can go further back. Put electrodes in the periventricular nodular heterotopia, but also in the occipital temporals and the other areas that were implicated. Keep going back. Okay. One more.
Yeah.
And so on those electrodes, we concluded, there you go, stop. The ROT, and the right side had a very complex network that involved the periventricular nodular heterotopia and the occipital temporal. So we ablated 4 corridors at that time with lit, one of which was a skip lesion. So we ablated the PBNH, and then we went up and did the cortical on that end. Why? Because the electrodes were active on that end. If you can get one more cut forward, you can see what we did. He did okay for about 3 months, which not too surprisingly, PBNH. He recurred after about 3 months this time. There you go. Those are the ablation corridors at the bottom of the screen. Up top, up top, you can see that the where the red dots were localizing the seizure onset zone. But anyway, 3 months later, he recurred. This time he's had seizures with nonsensical speech, but still he's having the behavioral arrest. So we repeated as non-invasive and an invasive, and you can see his invasive was very much concentrated on the left atrium and the complex of his PBNH. We found 2 seizure types, one of which was mainly in the PBNH, and the other one, regrettably, was in this mesial temporal lobe on the left side, obviously dominant. I ablated the other, so it's a no-go zone. So we ablated what we could. The parietal occipital temporal PBNH was the largest and the most active. We got that, and then there was another one on the right side that we ablated, but then we put RNS electrodes in his occipital temporal and in the PBNH that was the most active, just parallel to that, just lateral to the ventricle. One more slide over. You'll see where the electrodes are. There. Now we tend to put in 4 electrodes. We put in 2 actives and 2 reserves with the hope that one day we can plug in 2 more. And his others were activity found in the superior parietal and the inferior parietal PBNH. But these are his electrodes that are active now. And you can go to his parameters next. And he has done well. You know, it was a palliative approach. So you can see his histogram slowly coming down to greater than 50%, about 50 to 75% reduction in his seizures. You can see the RNS output off to the left, where the black is just the EEG, and then of course the blue is when it finds a seizure, and there it's stimulating the seizure. And here's a magnet swipe, and you can see the LOT electrodes and the LHT. The LHT responds to the heterotopia that's temporal. And you can see his parameters. He has 1,800 treatments a day. His duration is pretty wide. We've recently increased his stimulation to 2.5 millicoulombs per centimeter squared electron or current density. That's how it is measured. And I said we because I'm a liar, and the neurologists are the one that slave over these things for hours in the epilepsy clinic, trying each parameter. And we really found that a lot of these kids, it takes almost 2 years to optimize the stimulation. He's 4 years in. He's a success because he's a palliative resection. He's not seizure free, but he holds down a job, and he's doing well. So I presented this case with the help of Irfan Ali, who is our main neurologist, and Kim Hauk and Christina Trandifer have all contributed to his electrophysiology. So I'll leave that for discussion.
That's an awesome case, Dr. Curry, very complicated. Do you, when you reimplant to restudy these children after ablations, do you always put electrodes into the previously ablated corridors to prove that they're silent?
Sometimes not always. It depends on how suspicious I am. I have, in this particular kid, I didn't do like a phase 2B scenario where I put them in freshly. He did okay for a while, and then we recurred at 3 months, and it took us a while to get him worked up. So he's really being operated 1 full year after his first one. But generally, I do sometimes on a post-ablation electrocorticography, which is kind of the minimally invasive equivalent of the old 3rd phase of the TSC kids. I will put them down the ablated corridors just to be sure that the neighborhood is silent. And really what you're looking there is big field stuff. You're not expecting to pick up signal from ablated neurons, but you will pick up a field, and that's what we want to see.
Sure. Do any of the other panelists or faculty have any questions or comments you want to say before we sign off for the night?
I guess one question for Dr. Curry, do you stage these interventions? Would you ablate first and then see if the ablation is sufficient in cases where you've proven a multifocal epilepsy, or do you improve the multifocal epilepsy and then proceed with the ablation and the RNS essentially in close temporal association?
More the latter. We will ablate a few foci that we think neurophysiologically they can sustain, and I'll put in electrodes for the rest of them. And frequently we're coming into kids that have more nodes than 4. So we have to take some risks on some of the ablations. Some of them are pretty big. But generally, I want to do it all at once because I think we've proven that they are separate and that they're isolated and they're not connected.
I really want to thank everybody for tuning in. This has been a very informative live webinar with all the excitement that comes with it. Thank you to our listeners for tuning in today. I specifically want to highlight the effort our faculty put into this conference, and thank you all for your service to education, research, and clinical care. And thank you for taking the time to discuss your expertise and understanding of neuromodulation in children. Thanks to the NANS staff for putting together a professional and efficient webinar. We hope to see you all at the NANS National Meeting in January on my birthday, January 12th to the 15th in Las Vegas. Thank you.
Thank you so much for everyone.
Thank you.